Sex, politics, and the pelvic floor. How are they related? Welcome, GynoCurious listeners. I am Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. Today, I am thrilled and so grateful to welcome Dr. Uchenna Ossai to the studio. Dr. Ossai, who likes to be addressed as UC, is a sex-positive pelvic health physical therapist, sexuality educator, and counselor. She is a faculty member at the University of Utah and the University of Michigan, and she travels the world helping to teach clinicians and their patients how to heal the female pelvis. Welcome, UC. Thank you so much for joining me all the way from Texas.
Thank you for having me. It's a pleasure, absolute pleasure to sit with you today.
So I know you and I would agree that healthcare is politics. So I'm compelled to mention the fascist Italian PM, Miss Meloni, who just visited the White House. I know politics are complex, and we are not here to discuss why Biden might have invited her, but the administration just gave status to a woman who seemingly hates people of color, the LGBTQ community, and whose policies are certainly impacting Italian vulva havers' choices around their bodies. What are your thoughts about this?
I was very conflicted. Actually, I wasn't. I think it's absolute, let's use Biden's words, malarkey. Listen, we all need to play nice in the sandbox, but I think that is actually dated. I think that we can still play nice in the sandbox, but be like, no, but what you're bringing into the sandbox is bullshit. So please keep it at the bound borders and come correct. And I just feel that as the leader of the free world, you cannot celebrate people like that. For me, it just speaks to the underlying mistrust that I have, or that society should have, of the patriarchy and all of the systems and isms that structure resources and how we access and interact with our worlds. And so this was incredibly disappointing.
Yeah. You speak about intersectionality, how race, gender, sex, and politics affect our health and healthcare. Can you speak a little bit more about that? Because I think this invite to the White House is all about this intersectionality and the lack of insight into this.
Yeah, most of us are not raised with an intersectional lens. We look at our experience in a very tunnel visioned perspective, right? Or we only think of it as woman, man, Black, white, able-bodied, or using differently abled, able-bodied, all of those things. And so what Kimberly Crenshaw had introduced to us, first in legal briefs and writings, but mostly in a way to look at the world, is to say that all of our identities intersect and interplay with each other to look at how systems oppress us all differently. And as a healthcare provider and as a human in society, I approach life that way, and I approach my patients that way. And when you're only looking at one piece of it, if you're only looking at their gender, if you're only looking at their race, you're missing the entire story. And for me, my intersections are going to be the plus size, first generation American, right, Black, heterosexual, cisgender person. But that's going to mean different things for me in an academic space where I'm the only faculty member that's Black, right? Or that's going to be different when I'm in a healthcare space where I'm not the provider, so there's not that power differential. So the power differential changes when I'm the provider versus when I'm the patient.
Right on.
It's a completely different experience for me. I have fundamental distrust of the healthcare system, and that is a person who has been working in the healthcare system my entire career. And because as a Black woman, I'm like, I need to have two other people in the room, because I don't trust. It's not that I think that my provider is just racist, right? It's that I need to see that they look at me from an intersectional lens. I need to see that they understand what is in front of them. It's a different experience treating somebody who is white, cisgender, hetero versus a person that is white, non-binary, or trans, all of those things, even though they might, the commonality is that they're white, but they have other intersections that put them in different places in the world, that give them differential access, that impact their health, impact the stress that they live with on a daily basis. And if my healthcare providers or my friends or people in society are not at least aware of that, it makes it a more dangerous place for me. It makes it a more dangerous place for people who do not inhabit their identities in the same way they inhabit it in the same context in which they're inhabiting it.
The medical world, the teachings of the allopath has always been so binary. And talk
So
about
binary.
a sandbox full of binaries and isms. Oh my gosh, centuries long, right?
Century.
Yeah,
Yeah.
yeah. So it brings me to talking about the pelvic floor, because
Mhm.
not all pelvic floors are the same, impacted by all those things that you're talking about. And so let's just start with, I guess I want to say to the audience, first of all, I know most of you out there think physical therapists only take care of orthopedic injuries or somebody who might have had a stroke, but is a specialist. She is very knowledgeable, and her work is all about the pelvic floor. So, you see, what is the pelvic floor?
Absolutely. So the pelvic floor is a group of muscles, fascia, at the bottom of our pelvis. So it's anchored at the pubic symphysis in the front of our body, right? So where we have our navel and you draw all the way down, that bone right at the front, and then all the way at the coccyx, and then your ischial tuberosity, so your butt bones, right? So where you're sitting. And so those muscles are going to help support your pelvis, spine, and hips. They pump blood back up to your heart. They help pump the lymph fluid back into your lymph nodes, but they also help you with urination, defecation, and sexy time, if you so choose. Oh, and also birthing, if you decide to give birth. And so there's that. It's also very important for breathing mechanisms. So pelvic floor is what I like to say is it's a foundational muscle group that many of us actually aren't aware that it exists unless something happens, unless we give birth or if we have a problem, like prolapse, pain, constipation. Then you learn about your pelvic floor very quickly. But another group of people, when we're thinking about the pelvic floor, are the orthopedic folks, right? People with back pain, hip pain. Your pelvic floor is deeply impacted by that. So I tell everyone should be aware of their pelvic floor, no matter your gender and identity. And we should all be taught in ways to pay attention to it, to take care of it, and to address concerns when they come up. So that's the pelvic floor.
Thank you. Thank you. You already mentioned some of the reasons somebody might come see you, but can you elaborate again on what particularly vulva havers might say to you when they walk into your office?
Absolutely. So vulva havers, people who identify as women, usually they're going to say, I have urinary incontinence. I have issues holding my urine inside of me. And for some people say, I've been doing that since I was 10. I laugh too hard or I cough. But then usually it's going to be everyone's level of distress is going to be a little different. Everyone's vulnerable point is going to be a little bit different. So someone might have had this issue, but they wouldn't have thought it was an issue until they have a kid or until they have a surgery. And then they notice, oh my, I'm really wet. So that's one thing that comes up is urinary incontinence. And we can get more into the specifics of the types of urinary incontinence. You, urinary urgency and frequency. So feeling like you always have to pee or always going to the bathroom. So if you're going to the bathroom every 15, 20 minutes, it's awful and difficult, especially if you're going on a road trip, right? You have to stop every 20 minutes. It's very distressing. Oftentimes people come in with pain conditions, so vulvodynia, pain on the vulva or the vestibule, the opening of the vagina. We have dyspareunia, so pain with penetrative intercourse, and you can be deeper dyspareunia or initial dyspareunia, vaginismus, which is going to be your pelvic floor muscles. I call it like a Charlie horse. Charlie horse on you with anything going in, a speculum, finger, penis, toy, you name it. Constipation is a big one. Fecal incontinence is another big one. Pain related, just genital pain, it's related to endometriosis or any other disorders that can be accompanied that. Interstitial cystitis, so painful bladder syndrome, where people have pain with bladder filling or with urination, it's acid in your bladder. So those are just a few of the many things that I address with that.
Thank you. And the list is, I'm sure, longer than most people imagined. And there's more, just briefly, in terms of what happens before and after pregnancies and deliveries,
Absolutely.
just the aging process as gravity pulls down on all of our pelvises and what happens. So you mentioned this issue of identifying the problems. And one of the reasons I'm doing this podcast is I want our audience to find words, find space, find strength in speaking out about their needs. And in the world of patriarchy, in the world of medicine, women have so often been quieted, repressed, ignored. Yes, honey, we'll get to that, Pat. And I'm here to say enough of that bullshit, enough of it. We are 51%. We are the main users of the medical world. We influence who our partners go to see as an internist, et cetera, et cetera. So we have a huge voice and we need to speak out loud. So why do you think, maybe I just answered the question, but why do vulva havers have such difficulty identifying these problems and saying something to even someone like you who is so embracing?
Yes, so that's actually a beautiful question. And I'm going to try and answer that in as much of an intersectional answer as possible. So you hit the nail on the head. I think, first off, a lot of us are not given the audacity to advocate for ourselves in that way. And then when we do have the audacity, we come up against discrimination or a healthcare provider. And when I say discrimination, let me be clear, discrimination in terms of they may not want to talk about sex. They may not want to talk about your genitals. They may say, oh, I was taught a certain way, and what you're telling me is happening to your body. I don't have the expertise to manage this, and I'm not quite sure. So let's just put a Band-Aid on it, and hopefully it'll resolve itself. You have that issue. And then you also have just general bias. You have bias from providers looking at your size, your skin color, the fact that you're a woman, and you're saying, but I'm not enjoying my orgasms, which is another reason why people come to see me. And that's hard to say in general. So then when you bring it up to your healthcare provider and they themselves have not done the work on being comfortable with sexuality, which is a very important part of our health, they may push back and say, actually, that's not, I don't cover that. And they won't give you resources to help you address your concern. And then that further confirms that you probably shouldn't have said that, which is actually not true. So there's that piece, right? There's that for sure. We also have the fact that we're not educated about this early enough. We're not educated about this from childhood. So it's not a second nature for us to think about, let me protect my pelvic floor health. If I'm having pain with sex, if I'm having pain with putting in a tampon, if it hurts when I have a bowel movement, if my bladder starts to come down through my vagina, you're not immediately going to think, oh, I need to go see my gynecologist. I need to go see my women's health nurse practitioner or PA. That's not, a lot of us aren't thinking automatically that's what we need to do. Most of us are worried, oh, do I have an STD? Oh, do I have this other thing? Because we've been given this fear-based education about our bodies that hasn't really been in like a holistic abundance model. We're thinking about our body and health, which is really difficult. And then, of course, we have the stereotyping. No one wants to be stereotyped. So there's that fear of being stereotyped into, oh, you're a person that doesn't take care of yourself, or falling into a lot of the work or the research that I've been looking at lately is the racial stereotypes that people have. So then you have, because of someone's previous discrimination or the archetype they have, angry Black woman, for example, or the Jezebel, they're less likely to bring up concerns that open up a vulnerability, particularly around sexual health or pelvic health, especially if they haven't had a positive experience with the healthcare system, and not just them, but their culture, their race, their group. So there might be just an innate distrust in the healthcare system. So they're not necessarily going to access it as frequently as they should. And I really want to put that narrative out there, because oftentimes people say, oh, the reason why, especially certain minority groups, certain ethnic and racial groups, different gender groups, the reason why they don't have great health is because they don't have the money, they don't have insurance, all of that thing. And I'm like, yes, and that can be a part of it, but there's also that other huge piece where they don't trust the system. So they're not going to access the system as much. And then you're going to see some issues get to a point where they gets out of control, and then it's really difficult to manage it. So those are just some of the reasons people have it. And also, lack of expertise in the provider is also a big one. So
Huge.
a lot of our patients are bouncing from provider to provider, well-intentioned, but probably don't have a dream team of referrals to say, oh, hey, you know what? I'm not sure if this is a dermatological issue or a nerve vulvar issue. So let me send you to my vulvar derm specialist over here, or let me send you to my colleague that specializes in that. It's getting so much better, but it's still not as easy to access specialists as one would think it is.
Absolutely. And I want to add one more human feature, and that's of denial. That
Yes.
we all have some level of denial about a lot of different things, and we come to it in a variety of ways. Talk about intersectionality. So there are folks out there who are just unable to look at something, even that bulge coming out of their vagina, either until it gets to a point at which their body functions are being impacted or someone else says something. And I want to honor that. We are afraid and we are often ill-educated. And then all those reasons you just gave that we don't understand or honor our body. So I think it comes down to, yes, the hope that I have for our listeners is the point person, finding a person who can help you bring language to the problem, who can see you for all of who you are, and begin the journey. Because often it isn't just one practitioner, it's a group of practitioners. And it takes work and it takes time. But advocacy that you mentioned, that's what we need all patients out there to have for themselves. For better, for worse, we all need to learn how to advocate for ourselves. And it's hard. It's really hard. As you and
It is hard.
You're talking about yourself. I'm a physician and I walk in as a patient, and trust me, all those feelings, fear, denial, a lack of hearing, like, what do you say? I forget what that means. Oh my gosh, I can't appear stupid. All that stuff comes into the room. Yeah.
Absolutely. And shame, I want to just add in shame is a big one with denial. There's a lot of shame that vulva owners, women just have, societal shame. I wrote this piece a few years ago saying that shame, particularly for vulva owners and women, is like as American as apple pie in a way.
Yeah.
It's just how we have been taught and built to think of our bodies. And that's such a huge factor. Oftentimes the shame can be what keeps us, but then it's also what pushes us over the edge. And I've seen that both ways when in accessing care. I've had patients where I said, what took you so long? It's been a 20-year problem. And they said, finally, they felt shame, but it got to a boiling point for them where either someone else had brought that up, their partner had brought it up, or their child or a colleague. And they just said, I can't live like this anymore. Or they just assume this is what's supposed to happen to their bodies. And so that's just a big one.
Shame comes up a lot in this podcast. And I just had this vision that you and I need to start a new organization, and it's going to be called S.H.A.M.E. And we're going to find some new words to define that word in an acronym that is all about shouting and humanity and advocacy and meanness and effective conversation. Yeah.
Oftentimes people say you need to name the shame, and I'm like, yes, you need to name the shame in an environment that can hold the shame with you.
That's right.
So sometimes people are so brave and they come and they get to that appointment, but then the person just is irresponsible with that precious gift that our patients are giving them, or they fumble, which everyone's human. We make mistakes. Not everyone has the same approach, but just to persist in that advocacy for yourself is very important, because you'll find that right provider.
Yeah. So I just want to remind my listeners that I'm speaking with Dr. Uchenna Ossai this morning about her work as a physical therapist and sexual health counselor. So you see, your work just so beautifully integrates and weaves pelvic health with sexual exploration and pleasure. Most physical therapists I know don't talk about sexual pleasure when they're evaluating the pelvic floor. What motivated you to see this larger picture?
So when I was doing my residency many moons ago, I actually had a male patient, penis owner, talk to me. We were dealing with his post-prostatectomy, incontinence, and erectile dysfunction. And I just didn't have any information, even though, I had my doctorate, I finished school, I was in training, and I went to my director and mentor and I said, do we have anything on sexual functioning and pleasure and all this stuff? And I knew the didactic, there was some stuff, but I didn't have a lot of words for him and for my female patients and my vulva owner patients and my non-binary patients. And she said, that's actually a good subspecialty that you should focus on. And I said, okay, because I've always been interested in that. So I just started pursuing education in that realm, because one of the things that I've come to understand and learn is that sexual health and wellness, one's sexuality, all of that is very central to whether or not you view yourself as a healthy person. So oftentimes people who have any type of sexual distress or dysfunction, they're not going to view themselves as fully healthy. And that means a lot when it comes to your health and wellness in general. And oftentimes we minimize it as, oh, it's just this fringe extra thing that you get to have as a person. It's not core to your health. And I'm like, it's very core to your health. Very important, because so many things impact it: your cardiovascular health, your metabolic health, your hormones, musculoskeletal, everything impacts your sexual function and experience. And so we have to think of that as a central piece of our being and health.
And then there's the relational component to it,
Yes,
right? It's about who we partner with, who we are in relationship. Even if we're not talking about sex, we're talking about intimacy. And intimacy, as we know there's science that shows that when folks have supportive community, that they heal better. We know this.
Yes.
And this doesn't take illness per se to demonstrate this. It's everyday life, right?
Absolutely. Yeah. I have patients from all backgrounds, progressive, liberal, conservative, highly religious, but oftentimes people think that just being highly religious means you're conservative, and that's actually not true. But there's a lot of variety in the patients that I see, and one of the things that I like to empower them with is I'm not centering my comfort. I'm figuring out where they're at. I'm meeting them where they're at. And then I want to make sure that I understand what is the distressing component and what's feeding that, what their goals are, and speak to them in a language that works for them. So even though I'm saying everyone has a right to sexual pleasure is your birthright, masturbation is fantastic, I'm not going to lead with that heavy hand. I'm going to think, where is the distressing point in your life? And then provide them with information and education that is digestible to them, and that it works in synergy with their treatment plan and allows them freedom to explore as they see fit.
Again, it's embracing the, if you will, the cultural milieu and experience that people bring with them, and saying, we don't sit and speak English to someone who only speaks Spanish. If I'm going to be that simplistic, that it's about embracing and trying to understand all the reasons why they may not be able to say vagina, or all the reasons why they may not know, where's my clitoris? Or, sex has hurt ever since I started, and that's not normal. So, yes, bringing words, having an understanding as a healer that everyone comes with different baggage and history and fears, et cetera, and trying to tap into that. And I think for you and I'll speak for myself, but I just intuit this about you. That's where the magic is. That's where the healing is. That's where the intrigue is. That's where we get to take an individual who might look a lot like somebody else, but man, they are a different human being. Yeah.
Absolutely. And learning about what are the facilitators in their life? What are the barriers in their life? Considering, okay, what zip code are you in? What access do you have to those resources that we need to get you better? And then adjusting my treatment plan based on the fact that I know some resources may or may not be available to them. Being culturally, I don't even think culturally sensitive is a thing that I think about anymore because
Yeah.
that's just how I exist.
Yeah. Yeah.
It's just that it's so glaringly clear to me because I don't look at it from a lens of my own experience. But I will say, as a Black woman growing up in America, in Texas nonetheless, right? That's always a special experience. But
It's
growing
a
up in Texas,
trifecta. It's a
it's
trifecta.
interesting. Yeah,
Yeah.
Texas is that's my home. I'm still here, right? I was gone a little bit, but I came back. But I've seen a lot. James Baldwin once said in an interview, he said that he knows white people better than they know themselves.
Mm.
He has to.
Yeah.
He has to study them and watch them for his own survival.
Mm-hmm.
And so for me, I've just been studying my whole life. I even knew when I was 4 or 5 years old, there was a difference. And I knew that there are certain things I had to do. And my mom always remembers this story. She thinks it's funny. My dad didn't think it was funny at the time. But I was in first grade. It was Mrs. McDonald. I still remember her. She was the kindest woman, my favorite teacher of all time. But who doesn't like their first grade teacher? And she called my parents, and my parents came into the office or her room, and she was crying. And my mom was like, "What's wrong? It was something wrong with UC." And she, "No, UC's perfect." She said she wanted to know what everyone wanted for Christmas. And I said, I wanted to be white.
Mm.
And my mom thought it was so funny. And my dad was concerned. This isn't good. I was, well, what do you expect? She's the only Black kid in this class of white kids. I was in private school and I just wanted to be like everybody else. But my mom said her and my dad were double down on your Nigerian American, your proud Black little girl, and all this stuff. And I was like, I just want to look like my best friend Emily. It was that simple. But I understood that difference. And I understood the power differential at a very young age. So studying that and that experience, I think also, and my thoughtfulness about it informs my approach to health and wellness and education.
Yeah. Thank you for sharing that story with us. It's so profound how vulnerable we all are in one way or another. And pardon me, I'm not trying to create a hierarchy of what's more vulnerable than another.
Yeah.
But again, just trying to understand our patients and the differences and where they come from. You brought up that you're from Nigeria, and I was thinking about your origin story, and I had to, because we're talking about the pelvis and because we're talking about women, I had to talk about female genital mutilation, which is a practice that affects so many girls and women in sub-Saharan Africa and Asia and the Middle East. How does that practice inform you or impact your experience in your clinical practice? Are you seeing that?
I haven't seen a ton of that. I will say I've had many conversations with my mother and my aunties about it. And because my grandmother on my mother's side was a nurse, and most of my aunties were as well. I am talking to these Nigerian women who only my mother immigrated here. And it's very highly cultural, highly ritualistic. But the thing is, depending on the tribe, depending on the person that you're dealing with, some of my aunties said, I wish that it wasn't done to me because I want to be able to access pleasure in a different way. And my mom, I have permission to talk about this stuff. I got it years ago, but she said that her mother just cut her thigh and showed blood, did not cut her at all. Or my aunties by blood, because I have my aunties that are my mom's friends, but auntie's auntie. And my mom said she was very lucky that she had that experience because she was able to experience pleasure. But then as she It worked through menopause, all of that. And she's saying, I've also learned to understand that pleasure doesn't rest in my genitals. It rests in my experience and accessing her erotic sense of self and her inner power and all of those things. But again, I'm very lucky to have that experience and perspective. In a way, my mother was telling me, she's coming from a progressive part of our tribe and culture. You might have other people that have a different viewpoint. And so right now, the way I approach it is very individual, very cultural. I really specifically ask when I do have patients where that is the issue, where we're having a lot of scarring that is impeding their ability to urinate, have sex, menstruate, all of that. We're talking about, okay, what was the method? What was the belief? What can we do moving forward? How can we discuss this? So it is highly individually based, highly cultural specific. I often struggle because I'm very sensitive to the fact that I'm Western raised. I was born and raised in Dallas, right? So I have this American moral, no, we don't do this. But I also, there's people have a right for cultural autonomy, but did this person have autonomy? Did they have choice? Did they get consent? Did they know what was happening to their bodies? All of these conversations are very complicated, layered, and need to follow the guidelines of promoting one's health and centering their choice. And so even though I wasn't there at the onset of some of my patients' experience, I can promote that belief in my clinic, in my office, centering their choice, centering their health, progressing them forward, giving them the tools they need to advocate if it's their choice.
So one of the reasons that I brought this up was we're not so different in this country around cultural norms, I'll call them. In this country, there are surgeons out there who are doing more cosmetic than medical procedures, vaginoplasties, Botox injections, laser treatments. So I want to point out to our listeners that this is not just a phenomenon of those countries I mentioned or those continents, that we are in a country too where vulva havers are having surgeries for reasons that I personally don't always understand, professionally don't always understand. And I guess I want to hear your thoughts on that phenomenon.
Same. I don't always understand, personally or professionally. When we think about vaginoplasty, for example.
Why don't you explain what that is? I'm sorry, I used that word and we should define it.
Yeah, so vulvoplasty, those cosmetic surgeries are meant to change the vulva so it looks tighter or smaller. Labiaplasty. Thank you. Sorry, I need to correct myself. They want the vulva to look less fleshy, I've heard, or and I'm just speaking of that specific surgery. So it's plastic surgery, right? And so everyone has a right to do with their body what they will. And what I usually say to people is that we really just want to think about what we're looking to. Where is the distress coming from? Where is that feeling of dissatisfaction in their body coming from? Is it because they feel like the surgery will help them feel better, help them be in their bodies more? Look, hey, do what you need to do. But if it's about looking like someone else because you haven't had the opportunity to value variety, or someone else is telling you something is wrong with your body and then going into that process, or if you're still very young in your development as a person and you haven't had enough time and experiences to really understand and grow to love and learn your body. Because sometimes, and I also say this, I'm not anti-plastic surgery either. I think if you go into it eyes wide open and where the reason is coming from, then I say, I don't think that it's a problem. I don't always understand it, but I respect a person's choice.
I remove judgment. I say, if this is what you need to do, as long as you have thought about all the ramifications, pros, cons, potential risks, then yeah, I agree with you. Who am I to say?
Yeah.
And particularly as I age and this question of plastic surgery around the wrinkles and the chin and all the other parts of my body that are changing. I want us to be as respectful of our pelvis as the rest of us. So if that's where you're going, I've got to respect that.
Yeah, I'm pro what's going to make my patient happy
Yep.
as long as they're not being coerced.
Yeah.
And then it's more about educating versus getting them to agree with me. It's just more like, this is the information that would be helpful as you move forward in this choice.
That's right.
And that's where I just want to make sure people have the information and they're like, I made this decision. I'm going to do it. Cool. I support you.
So we're going to pivot a little bit. What is sexy time? You've mentioned it and you write about it. What is sexy time?
Sexy time is sexual activity, having any type of sexual activity that you enjoy. And I started saying sexy time because as a provider, I found that it just landed softer for a lot of my patients if I said, talk to me about sexy time. And then it's very disarming, right? It doesn't feel as intense when I say that. And so it helps to relax people and make them understand this is a safe environment if you feel like you want to approach all of those things. And I do make the effort, and it's important that a lot of the readers know this, that 82% of patients want their provider to initiate the conversation about sex. And not everyone has that experience, but not all providers are comfortable doing that. So I want people to know that even if your provider doesn't ask, it doesn't mean that they're not willing to help you. They just may not be in their mental script when they're interviewing you or when they're working with you, but bring it up. And if your provider doesn't know what to do, most of the time they're going to say, I am not the expert on this, but I'm going to send you to someone that is. And that's a beautiful response.
Yes,
because
it's honest.
then they're acknowledging it's honest. They're acknowledging your concern by giving you a referral to someone that they know is skilled and has the clinical expertise to address your needs.
We know the reason that women, vulva havers, don't mention sex is actually all the same reasons that clinicians don't talk about sex.
Yes.
That we're all human, and that the fear, the denial, the embarrassment, the lack of language. Science has demonstrated really only about 20% of GYNs, OBGYNs, will ask the question, are you having sex? Is sex pleasurable? Are you having any concerns? And
Yes.
that's remarkable, because if it ain't happening there, where is it happening?
Right.
Yeah.
Right.
Yeah. So how often will someone come into the office and have the experience of pelvic pain, but they're not connecting it to sexual experiences, sexy time, where they're not connecting the two? How often does that happen?
Happen as often as you think. So people present with pain, usually in my office, and they might have abdominal pain, rectal pain, vaginal pain, and they'll say that it's worse with sex, or sex doesn't impact it, that type of thing. Or their pain is specific to the act of sex, whether that's arousal, just being aroused. They might have pain in their clitoris or vulva or vagina, or it could be just penetration. So oftentimes pain is, I call it like a very not fun glitter. It just messes with everything. And so sometimes our patients are connecting it with sex, or they say, yeah, sex hurts, and so does peeing, and so does pooping, and so do all these things that are highly functional. But I will say the patients who have painful sex, when they come in for that reason, oftentimes they're shy to talk about it, or it's hard for them to, even though I see it clearly, like the diagnosis and everything, then they've talked to their gynecologist who's referred them to me. I still have to peel back the layers. And that's okay, because I have a trauma-informed approach to care. Safety and trustworthiness and transparency is bedrock. Once they have that trust in me and they feel that sense of safety, usually they can open up a little more, depending on their view on sex, right? Because you have a lot of purity culture, you have a lot of shame, you have a lot of things that people hold close to their hearts when it comes to sexual functioning, partnered or unpartnered.
Yeah. Yeah. It's all part of the question I have for you around, so what do we tell our listeners about just maintaining and protecting their pelvic health?
Yes. So first off, I want everyone to think about their pelvic health the way that they would their back health, their abdominal health. It's a muscle group. So it needs to be exercised, it needs to be stretched, it needs to be utilized. And so I'm not telling everyone to do Kegels. That's a whole other,
Whole other podcast.
a whole other podcast. I'm not telling you to do Kegels blindly. I'm just saying that what we need to think about is think about your urinary function, think about your bowel function, your sexual function. And if you're finding that the function isn't optimal. So if you're having leakage or if you're having difficulty emptying your bladder or your bowels, right? If you're having pain with sex, even if you're not having pain with sex, let's say you're sexually active and you're noticing that your orgasm experience is different and not in a great way, right? Or if you're noticing that you're just feeling that you're noticing something dropping or heavy in your pelvic floor, I would first go to the doctor immediately, if not sooner. And if they're not addressing your needs or if they're not acknowledging your needs, keep going until you find somebody that can.
Yeah.
And I think that's the most important thing. Because oftentimes people think, should I do Kegels? Should I do dilators? Should I do this? And I don't know. Because I have to assess your pelvic floor as a system. Yes, I do a pelvic floor assessment. So that means, would you like me to explain that? Or
A little bit. Yeah, go for it.
Yeah.
Yeah.
So pelvic floor assessment is similar to a pelvic exam, except I'm not inserting a speculum. I'm going to insert gloved fingers into the vagina or the rectum to assess the pelvic floor muscle strength and the nerve integrity and your coordination and control. So I'm going to look, are the tissues symmetrical? Is one side drooping and the other side isn't? Can you feel everything the way that it should? Or is it painful? If I lightly brush against the vulva with a Q-tip, does that hurt when it shouldn't hurt, right? So that will give me some ideas of what's going on. Can you squeeze? When you squeeze, how strong is it? Are you able to let go? So oftentimes people are great squeezers, but they can't let go. So they're just holding on with a fist all day in their vaginas. And
Right.
I'm like, ooh, this is a problem. And so then can they do that when they breathe? Does their pelvic floor lengthen? So your pelvic floor, just as it should contract, it should also lengthen. So I'm assessing all of those things. And depending on what you're presenting with, I might do both a vaginal and a rectal exam. So that's what that is. So that's why I tell people I don't just blindly give you pelvic floor exercises because I don't know how your pelvic floor is functioning.
Yeah, thank you. So we're coming to a close and there's so much that we can chat about. And I've decided that I'm ending my podcast now with the word pleasure. And I just want to put it out there. When the world feels so heavy and politics and economies and sexism, racism, all of this stuff that isn't aligning with our professional and personal hopes and dreams, what do you do for pleasure? How do you cope briefly with the heaviness of it all?
Water. I'm a water baby. I love the water. I can be in any pool of water, ocean, lake, river, pond, kiddie pool, stock tank pool, big pool. I don't care. I love it all. Part of my self-care this summer, because Texas has been disrespectfully hot, I'm actually taking it personally, but it's okay. There's this great pool in Austin called Deep Eddy Pool. It's fed by fresh spring water and it's cold. It's very cold. It's cold for us. It may not be cold for people in the Pacific Northwest or up north, but it's cold for us. And it's been very therapeutic to go and just swim and float and and that gives me so much pleasure and joy, and it changes my mood completely because I'm not sweating. I'm cool, and it's also nice to be around in a public pool where people are happy and swimming and frolicking. So that's also a nice sight to see.
I wish you the proximity of water of any sort without it being floods and storms in your life throughout. Thank you so much for inspiring all of us to learn more about our pelvis, to be aware of the intersectionality of sex, politics, and healthcare, and its very significant impact on all of us as individuals and as communities. Thank you.
Thank you.
Thank you also to my producers, Jen Hammoud and Maddie Rosenberg. Please join me each episode, and if you like what you hear, subscribe, follow us on whatever podcast app you are listening on, and share with your community. Until our next conversation on GynoCurious, please stay healthy and stand strong with your knowledge, insight, and intuitions.